For those of you that don't know me, my name is Zoe. I am one of the public health dietitians here at the Northwestern Health Unit. And we're talking about food insecurity today, specifically here in Northwestern Ontario. We have a lot to talk about, so I'm going to get things rolling. So food insecurity is a really hot topic in both our personal and professional lives lately. Food insecurity is a really large, complex topic, which we'll see a little bit today. But hopefully, through today's conversation, you walk away with a basic understanding of household food insecurity, including the causes and implications to health, what food insecurity is really looking like for people in Northwestern Ontario, and challenging you to explore strategies that you can apply in your practice to support clients, students, patients who may be experiencing food insecurity in your role. As an FYI, I will probably unconsciously use patient and client kind of interchangeably today, recognizing that we have a mix of providers on the call. I'll also be shortening household food insecurity, which is the proper term, down to food insecurity, just to save myself some words in a few places, but just know that those are also interchangeable here. We will save questions to the end. You're more than welcome to throw them in the chat, just so you don't lose your question if you'd like, but I will wait until the end to address any of those. So given today's topic, I do want to take a moment to recognize that I really am speaking to this topic from a place of privilege. I am a white, able-bodied woman with a post-secondary education who has had both the choice and opportunity to live, learn, work, and play across Turtle Island, including the beautiful and abundant Treaty 3 lands where I currently reside and speak from today here in Dryden. Food is really deeply personal to every single one of us. And we know colonialism, discrimination, stigma, and Western views of health and superiority have had tremendous harms on the Indigenous peoples in Canada and their relationship with food and traditional foodways. And as a dietitian, as a nutrition professional, I'd like to acknowledge the harms that this field of work really carries. Our nutritional science in Canada today was influenced by unethical nutrition experiments of intentional restriction, deprivation, and starvation conducted on youth in residential schools. And these experiments were led by a federal team of researchers who later authored the first rendition of Canada's official food rules, which was a precursor to the first food guide here in Canada. These harms and continued harms happen despite the fact that my colonial ancestors wouldn't have survived without Indigenous knowledge of the land and foodways. And in our current fast-paced and industrialized world, we are again seeking knowledge and opportunities to reconnect to the land and to our food. And we really can't do this without the expertise of the people who kept these lands for millennia. I also want to preface this presentation by saying that I am by no means an expert on this topic of food insecurity. Although I am a trained health professional, working within this topic area, I do a lot of work specific to food insecurity. As you'll see through today's presentation, it's really multifaceted, it's really complex, and it's intertwined with a lot of sectors well beyond just the topic of food and nutrition. And although I've had periods of struggle in my otherwise privileged lifetime, lived experience is unique and varied to each person, and the voices of those experiencing food insecurity hold tremendous value and arguably more value than mine does today. And we know that education and awareness alone isn't a solution here, but I hope having a shared understanding and recognition of this topic is a step towards us breaking down some of those structural inequities that exist and contribute to food insecurity in the North. So, in its most simple, straightforward definition, household food insecurity is inadequate or insecure access to food, primarily due to financial constraints. So that might mean worrying about having adequate amounts of food or having a limited food selection. They may experience a compromise in quality and or quantity of food, or there's inadequate amounts of food leading to reduced food intake, missed meals, or at the extremes going a day or days without food. The picture of food insecurity is especially complex here in Northern Ontario, as there's a lot of compounding factors that influence food insecurity both directly and indirectly. And most of these are outside of our individual control. That includes housing affordability and availability, climate or ag impacts on our local land and waterways, the continued detriments of colonization, isolation, and discrimination, as well as our northern food supply chain, where we're seeing high food and transportation costs and at times a compromised food quality being transported. To further complicate things, we know global events between 2020 and now have really impacted the cost of living significantly. Through the COVID-19 pandemic, we saw labor shortages and supply chain disruptions, increases in oil prices and therefore our transportation costs. At a global level, we're seeing food production impacted by climate change, including droughts, flooding, and historic heat waves, as well as global conflict influencing food, such as the war between Ukraine and Russia. Here in Canada, we're seeing grocery giants reporting record high profit margins despite the coexisting record high inflation in recent months. And that's impacted the cost of many goods, including food and housing. So rightfully so, with all of these other factors, the most common rebuttal in conversations around food insecurity is that the cost of food is the issue and not income. And there is no denying, especially in our current economic context, as well as those unique circumstances of the North, food costs do play a small role in otherwise income-driven food insecurity. And if we step back and look at trends over time, the cost of food has increased at a fairly steady rate over the past 100 years. You can see the small blip kind of post-COVID on the right side. In contrast, median Canadian incomes have fallen behind the cost of eating and living, and that gap has grown exponentially since around the 2000s. And keep in mind that this is median income. We know that the effects of rising food prices is not felt equally for everybody. Those with higher incomes can protect themselves from the pressures of changing food costs by adapting their budgets, whereas low and fixed income earners are forced to make hard decisions between food and other expenses like bills and housing. So that's a really quick overview, but as you can see, food insecurity really is this complex issue that's influenced by political, economic, and environmental landscapes on a regional, national, and global scale. And I like to point this out to paint a picture right off the get-go, just to talk about the complexity of this and that it really is more than just food, despite the name food insecurity. For the remainder of the webinar, the focus on food insecurity will be as it relates to finances, as this is how we define and study food insecurity in Canada. And the evidence has shown that food insecurity is a strong predictor of material deprivation and that income-based solutions are really what is effective at alleviating food insecurity. So across Northern Ontario, we're seeing really high rates of food insecurity, meaning we're all regularly interacting with clientele experiencing food insecurity. Approximately 1 in 5 households in the Kenora-Rainy River District faced food insecurity in 2022. This is the most recent regional statistics that we have. And I like to point out that this is likely an underrepresentation of food insecurity in our region, as this data comes from the CIS Statistics Canada data, so Canadian Income Survey, and it does not include those that live on First Nations communities or other small remote areas. So across the Northwestern Health Unit catchment region specifically, there are approximately 40 First Nations communities that are excluded from this picture, as well as other small remote communities and those experiencing homelessness. So given these exclusions, we can assume that this already high number of 1 in 5 households is actually a gross underestimate of true food insecurity in our area. And we're only seeing food insecurity get worse both locally and nationally. Recent statistics were just released from Proof, and they showed that between 2022 and 2023, food insecurity in Ontario increased from 19.2% to 24.5%. so about 5% increase. The percentage of children under 18 living in a food insecure home increased from 24.6 to 30.7%, so a third of children. And across the 10 provinces, 36.8% of people that identify as Indigenous live in food insecure households. And again, this does not include those that live on reserve. We know that food insecurity can really affect anyone, especially as we're seeing some of the highest rates of food insecurity in Canadian history. However, we know in Canada that certain people are hit hardest. As mentioned already, Canadian literature shows food insecurity is racialized. Up to 70% of households on reserve and over 30% of off-reserve Indigenous households are estimated to experience food insecurity. Individuals that live alone or single-parent households also experience very high rates of food insecurity. And those living on fixed or low incomes experience some of the highest rates in Ontario. Almost 70% of Ontarians that receive Ontario Works or Ontario Disability Support Program allowances are food insecure. Even though this is a few years out of date, I really like sharing this figure from Feed Ontario's Hunger Report in 2021 to really put that food insecurity on fixed income into perspective. So the top line where I've got the red arrow shows that for in rural Ontario, such as Dryden, where I'm speaking from today, someone on Ontario Works would fall approximately $1,000 below the poverty line every single month. And someone receiving ODSP would fall about $650 below the poverty line every single month. And given the cost of living has continued to increase since 2021, we can assume that this gap has only grown. We know that having employment isn't necessarily enough to protect from food insecurity either. Almost 60% of all food insecure households in Ontario are part of the workforce, which speaks to an inadequate minimum wage and precarious work opportunities that don't support the current cost of living. The Ontario Living Wage Network, who calculates an estimated living wage across several economic regions in Ontario, released their 2023 report in the fall and found that a basic cost of living requires almost $20 an hour in Northern Ontario. You can see in the map there is $19.80 an hour. So food insecurity is known to be a strong measure of material deprivation or poverty, tightly linked to indicators of social and economic disadvantage. What this means is that when money's tight, food becomes a flexible expense in order to fulfill other basic needs like housing. And this is really important because it means that food insecurity isn't just about not enough food. It's likely an indicator that other basic needs for health and well-being are being compromised or unmet. And this is where we can start to see the connection between food insecurity and health outcomes. There's a ton of evidence in Canada that those experiencing food insecurity suffer worse health outcomes and poorer quality of life. They're at higher risk to develop mental health and physical health conditions such as diabetes, cardiovascular disease, bowel disorders, and depression. They're more likely to be diagnosed with multiple chronic diseases, have more frequent hospitalizations and longer hospital stays, and ultimately experience a shorter lifespan, almost 10 years shorter than someone who is food secure. And food insecurity can be both a determinant of health and an outcome of poor health. And this can become a vicious cycle. I really like this image from Alberta Health Services to help visualize what this cycle can look like, of how food insecurity can lead to a decline in physical and mental health. And in turn, how poor health can make it really difficult to become food secure or improve food insecurity status. So I'm a big contextual person. I like real world scenarios. So this case isn't a real case. This is based off of a document from Alberta Health Services, but I've incorporated some local data into it just to give that real world picture of what we're talking about. So let's talk about Jerry. Jerry currently lives alone in a rented apartment in Kenora. He's been divorced for a while, but he maintains a strong relationship with his two sons who live away in Thunder Bay. Jerry recently suffered a stroke, leaving him with long-term health impacts, and he's been unable to return to work due to his medical prognosis. Although his employment income was enough to pay his expenses while he was working, he put aside very little in savings over the years. His employer didn't offer a great benefits package and offered no short or long-term disability plans. Now that he's unable to work and has recently been approved for ODSP, he's concerned how he will continue to pay for his existing expenses like rent, utilities, and food, as well as his new medical costs. After paying for his small one-bedroom apartment in Kenora, Jerry only has about $173 left for the month from his ODSP allowance. To feed himself well, Jerry would need to spend around $539 a month for food, putting him in the hole by over $350. So where's the compromise? What's got to give, right? How does Jerry decide between buying nutritious food, heating his apartment, and transportation to his physiotherapy appointments? So let's look at this a little further. Let's say that on top of Jerry's recent stroke, he's been managing diabetes for about 10 years with the help of a local clinic. Now that Jerry's on ODSP, he's feeling the strain of having a low fixed income. Food insecurity is about financial constraints, which means clients may be making hard decisions about where that limited income goes in terms of food, transportation, healthcare, or housing costs. The health impacts of his stroke may mean he can no longer drive himself independently and now relies on other modes of transportation, which he might have to pay for. He may start relying on emergency food like the food bank to help cut costs, but that might mean sometimes the quality or quantity of food isn't always supportive of his dietary needs, leading to poor blood sugar control. All of these decisions about where to spend his money, time, and effort can lead to feelings of embarrassment or shame or guilt about struggling to meet care plan goals or deter him from attending his appointments regularly. Maybe he's socially isolating himself from friends or family and colleagues now that he's experienced this life-altering event. And all of these feelings, all of these stressors can lead to health outcomes. Maybe he's seeing his blood pressure increase as a result. Maybe he starts testing his blood sugars less due to time constraints or feelings of frustration or simply not having access to adequate testing equipment. And all of this can lead to increased risk of complications related to both his stroke history and diabetes and the need for more complex emergent care or even hospitalization. So this isn't to say that all of these things are going to happen or be experienced by Jerry, but it's, again, just to pull these pieces together of how complex food insecurity can be, and that it's so much more than just the food piece, that it's an indicator that other basic needs are being compromised. So in Ontario, public health units are mandated to monitor food affordability, and most Ontario health units do this every year or two, led by their dietitian team. This includes costing a standardized list of food across our region to monitor both food accessibility and affordability and how this compares to different income scenarios. Health units share this data and usually an accompanying report publicly with the intent to raise awareness around food insecurity and income-based solutions that address it. So here at the Northwestern Health Unit, our 2023 report was released earlier in April, and it is live on our website. I did use some of this 2023 data in Jerry's case study, but I do want to quickly show you just some of our other income scenarios in more detail. These income scenarios are really, to me, the important and tangible part of our reporting because it really helps visualize that gap between incomes and the cost of living. So this is based on the Kenora Rainy River districts. Feel free to connect with me if you want more details about how these are calculated. There is also some details towards the end of the 2023 report that provides a little bit more context. But as you can see on this slide, we have 4 family household scenarios, all with different incomes. And then across the top, we have total monthly income, which includes all eligible tax benefits, the cost of rent, which is based on local data that was collected across the region in 2023, And then the cost of food, which was based off of our 2023 nutritious food basket costing. So as you can see, a household with children receiving Ontario Works is $650 in the hole just to afford nutritious food and housing for the month. For a household with a full-time minimum wage earner, they end up with about $700 left. But these remaining funds are expected to cover all of their other basic needs for the month, whether that's heat and hydro if it's not included in their rent, childcare, clothing, transportation, school supplies, phone bill, Wi-Fi, medications, and anything else that might come up throughout the month. This table is the same in terms of the structure of it. It's just now showing single person households with various income sources. And again, not to go through these quickly just for the sake of time, but they are also in the 2023 report if you wanted to look at them in more detail. So again, from this chart, you can see that an individual receiving social assistance, so whether it's OW or ODSP, is in debt after just paying for rent and nutritious food, leaving no money for those additional expenses that I just mentioned, like utilities, phone bill, transportation, household supplies. Compared to the single households on social assistance, you can see the slight protective effect that the old age security and guaranteed income supplement has for a single person over 65. This is a form of basic income in Canada. Statistics actually show that once people with lower incomes turn 65, their risk of food insecurity is halved. So it goes down by 50% due to the existence of this income guarantee. We also see self-reported rates of physical and mental health improve dramatically after Canadians move to that guaranteed income at the age of 65. We have other Canadian examples of basic income guarantees. Some of you may remember the Ontario Basic Income Pilot Project that started in 2017 and was unfortunately cut short due to a change in government. Despite the fact that it was cut short, there was actually a lot of promising results that came out of it. Participants reported better health outcomes, mental health, less hospital visits, and better overall quality of life, including less food insecurity. They skipped less meals. Food bank visits decreased by almost 70%, and approximately 85% of participants reported an improvement in the quality of their diet, such as more fruits, vegetables, and quality meats. And there's been some really great studies with participants from the pilot that have captured quotes like those on the slide here on how the experience impacted their life. Another basic income guarantee pilot happened back in the 70s, and funny enough, happened in my hometown in Dauphin, Manitoba. So Dauphin was used as a saturation site to do a basic income pilot, and at the time was a really ambitious social science experiment for Canada. Unfortunately, similar to the Ontario basic income pilot, it was stopped due to a political changeover in 1979, but also saw some really great benefits in the short time that it was ran. Probably one of the biggest critiques of basic income guarantee programs is that they will deter people from seeking or maintaining their employment because they're receiving that basic income. Both the Mincome study and the Ontario Basic Income Pilot showed that employment rates actually stayed the same. However, in the Mincome study, there were two groups that actually stayed out of the workforce because they were receiving Mincome. That included new mothers who chose to stay at home longer with their newborns, and teenage boys who stayed in school to graduate instead of dropping out before grade 12 to work and support their families. The Mincome study also saw decreases in domestic violence, work-related injuries, farm and motor vehicle accidents, and hospitalization rates, while seeing improvements in mental health, high school graduation rates, and university enrollment. So we have quite a bit of Canadian evidence that really speaks to the need for these system-level interventions for food insecurity, specifically income-based solutions to ensure people can afford the cost of basic living and health. The examples that we just talked about, like old age security and the 2 basic income pilot projects, are perfect examples of income-based solutions. Of course, we know that implementing something like this could take a long time, but it would ultimately be addressing the root cause of food insecurity. In Canada, we have several organizations that are doing amazing research on this topic and the solutions needed to address it. The main one being Proof out of the University of Toronto. They're really the leaders in food insecurity research, and we're the ones that just released those new statistics on Canada and Ontario food insecurity rates. But we're even seeing food charity organizations like Food Banks Canada and Community Food Centres Canada actively calling on the need for income-based solutions. So like most health topics, food insecurity interventions really fall along a continuum. In public health, we like using this upstream, downstream language. There's a lot of different descriptions or visuals online if that was unfamiliar to you, but generally speaking, downstream interventions tend to be a little bit more reactive in nature and are more individually focused interventions. Upstream interventions are really trying to tackle that root cause and are impacting a community or group of people systemically. We just talked about upstream income-based solutions, but of course we know that those upstream solutions take time and work, and interventions at the midstream and downstream levels are still really important in the meantime. So I do want to talk about these specifically. So if we flip to the opposite end of that continuum, we have food-based programs, which are a downstream approach to food insecurity. These tend to be the most visible interventions and programs when we're thinking about this topic. This is, food banks, food boxes, community kitchens, community gardens. And these programs have a ton of benefits. They alleviate short-term access to food. They may provide some social connection and community connectedness, food skill development, and they play an important role in meeting the immediate needs of vulnerable community members. However, they're not effective approaches to reducing food insecurity itself because they aren't addressing that root cause, which is inadequate financial means to access food. If we look at the example of food banks are doing incredible work to really meet people where they're at and fill a gap, but they were never meant to be a long-term solution. We know that despite really high food bank use lately, the majority of people experiencing food insecurity don't even access these programs in the first place, whether it's due to barriers like transportation, hours of operation, cultural appropriateness, eligibility, or just the perceived stigma around using a food bank. And these programs, again, aren't resolving food insecurity because they aren't addressing that root cause. So although accessing the food bank today means not being hungry, that person is still food insecure. Let's look at community gardens as another example. So community gardens are an incredible asset to communities. I think every community, they beautify land, they improve participation in food procurement, contribute to community resiliency, and to some extent sustainability. They're also a fantastic opportunity to spend time outdoors and be physically active and learn new skills and increase social connectedness and build a sense of community. However, given our short growing season, a community garden plot will only provide fresh produce for a short period of time for an individual or household. Also, if someone is already experiencing food insecurity and therefore other material deprivation, they may not have the available time, finances, transportation to utilize community gardens, or may have other competing priorities like childcare or precarious housing or experience other social barriers. As a society, we tend to carry a lot of assumptions and biases when it comes to health and health behaviors, especially when it comes to food. However, it's important that we recognize healthy eating looks different for every single one of us. Suggesting that a low-income household just needs to learn to budget better or have better food skills can actually be really marginalizing and makes assumptions about a person's circumstances, intelligence, skill set, and capacity. We also have Canadian data that people in food insecure households actually have equivalent food skills as someone that's food secure and actually shop on a budget almost twice as much as food secure households. So in 30 minutes, we've talked a lot about what food insecurity is, the implications it has to health status and accessing health. We've looked at some scenarios to really visualize how food insecurity is more than just food. It's a marker of material deprivation and likely compromised basic needs. We also saw that food insecurity is really high across our region and continues to rise across the country. And therefore, we're likely to be interacting with clients affected by food insecurity on a regular basis. Because of this, I think it's really crucial we're considering food insecurity in our communications, assessments, and interventions for care with any clients that we're working. I will preface this final section by saying I haven't thought up any new or radical strategies to share today, but I hope this conversation challenges you to think about your current client practices, what you're already doing and what there's opportunities to do, and how that translates into supporting clients with food insecurity. So we talked about upstream, we talked about downstream. Now we're going to talk about what is kind of considered midstream approaches. And when it comes to food insecurity specifically, to me, these are ways that we can increase existing income and or improve access to basic needs. And I think this is a really great spot for us in the health and social services to feel like we're doing something tangible that isn't necessarily just downstream work, but recognizing that the upstream work will take time. So let's talk through a few examples. And none of this list is exhaustive, but again, I hope it provides you with some examples and ideas. And maybe some of you have ideas or strategies that you're already using within your organization that you're willing to share. So the first one being providing free taxi vouchers or bus tickets at your organization. This can really take away transportation barriers for clients when they're coming to and from your facility. And it frees up that existing income or money for them to use on other basic needs. Offering modified business hours, even if it's 1 day a week, can help working clients access care and services without disruptions to their working hours and pay. The COVID pandemic really expanded our use of telehealth modalities, including video and phone appointments, and these can be a really great tool as well. Even though in-person visits are non-negotiable for certain care and assessments, that's understandable, virtual or phone visits can have a benefit to improving access to care. One recent study showed a significant decrease to no-show rates. They found in-office no-show rates are about 36%, whereas they're only 7.5% for telehealth options. And most importantly, they save clients both time and costs associated with traveling to care or appointments. This leads to higher client satisfaction and also is reducing interruptions to their working hours or their family time. Organizing or partnering to host a free local tax filing clinic is also a really cool way to provide income-based support to community members and clients. These are volunteer-run clinics, and you can organize them through the CRA website. And it's basically an opportunity to offer low-income individuals and families an opportunity to file their taxes and ensure they're receiving all the tax credits and benefits they're eligible for. So again, maximizing their existing income. Helping clients find and apply for housing or employment and training opportunities are also income-based solutions because, again, they're helping increase income or free up existing income. We've also seen a general increase in accessibility services through COVID. Obviously, this varies across the region and by community, but things like if a pharmacy offers medication delivery or some grocery stores are offering pickup or delivery. Again, these are transportation examples that are increasing available client income because they may not have to allocate that to extra taxi trips or parking lot fees. So again, these are just a few examples of what midstream approaches to food insecurity can look like. For those that are more client-facing providers on the call today, another midstream intervention can be implementing poverty screening for all your clients. So this specifically on the slide comes from the Center for Effective Practice and is their poverty tool. And it's just asking one question: do you ever have difficulty making ends meet at the end of the month? Because poverty is a strong risk factor for multiple chronic conditions and, of course, food insecurity. Integrating poverty screening into client assessments and interdisciplinary care and communication can trigger appropriate investigations and interventions, leading to improved client care. Of course, I did spend some time working as a clinical dietitian before I was in public health, and I know from that time that talking about income can be really hard and uncomfortable and sometimes feel out of scope, especially if we don't know what next steps would look like. And there's a lot of Canadian studies that have found most healthcare providers feel this way. However, these studies have also found that 93% of clients think that being asked about their financial situation relates to better health outcomes, and that almost 70% of clients would be comfortable being asked about their financial strain. And I like to emphasize here that I think we all need to hear this when we're client facing, when we're working in the health and social services, that asking about financial strain is not about solving a client's financial problems, because we may or may not be able to do that. Instead, it's about understanding how a client's financial situation could be affecting their health and well-being, and how that affects their care plan and impact their ability to afford basic needs. So, in other words, you're not necessarily responsible for solving their financial strain or food insecurity, but knowing this piece of information about your client is a really valuable tool to understanding their overall care needs and planning interventions accordingly. And I think one of the most powerful ways we can support clients as health and social service providers is through connection and knowing both our facility and our community to help clients navigate the system effectively to meet their needs. I try not to dive too far into specific articles, but I really like this study that was done in a Toronto hospital just a year or two ago, because it really highlighted some key takeaways that are really relevant to today's conversation. It was specific to inpatients at a hospital, but I do think it transfers across to outpatient situations and social services as well. So the study conducted a bunch of patient interviews and summarized the key themes of that. One being that patients or clients know that healthcare settings are feeling really stretched for resources, for staff, for time, and they understand the realities of what can be done in those circumstances. However, what I thought was really cool about this study is that there was an overwhelming desire from these patients for plain and simple connection in a few different ways. One being connection with their healthcare provider through compassion, trust, and providing non-judgmental and trauma-informed care. Connection in terms of understanding them as a whole person. Patients recognized that their unmet social needs largely influence their lives and health, and felt that their care needs better if they were aware of these unmet social needs. And connection in terms of outside of the healthcare setting. So providing acknowledgement that the social environment is largely influencing their health and helping them navigate the system to have awareness and access to community resources. So to me, connection is a really key piece of this conversation. The clients we work with are really experts of their own lives and are key in understanding their own care needs. For some, getting help to access food-based programming may still be beneficial and be meeting their needs well. For example, you may be talking with a client that's never accessed the food bank before and feels really overwhelmed about how the process works. However, it's important to keep in mind that not all clients will benefit from or even feel comfortable using those services, and that's also okay. Because we're talking about food insecurity, of course, dietitians can be a great connection here, whether it's managing a new diagnosis or existing health conditions. They're at malnutrition risk. A nutrition assessment may be warranted for some people. However, most clients experiencing food insecurity will benefit most from income-related referrals. So this could include social workers, caseworkers, patient navigators, and community service organizations that liaise and connect clients to things like what we talked about as midstream approaches, like housing applications, income tax filing, employment and education opportunities, and transportation services. Social prescribing is also a growing topic in healthcare. I think we're recognizing more than ever the deep connection between our mental and physical health. So connecting clients to events and classes in the community that help them feel socially connected and be part of joyful activities is also supportive of their health. And finally, I think it's important as any client-facing provider that we're constantly reflecting on our internal biases, assumptions, and practices. For most of us, being in the health and social services means we probably carry some level of privilege. We probably have some level of education behind us, make a reasonable income, have some level of stability to our work, and most importantly, we have the time and resources to access health. For many of our clients, this isn't the reality, and with competing priorities and stressors, health isn't a number one priority for everyone, and that is okay. Of course, something like poor blood sugar control has harms and risks that as a healthcare provider, we may need to ensure that our client is informed of. However, finding somewhere to live, helping a struggling family member may take precedence over thinking about diabetes management. And again, that is okay. Health looks different for each of us. And we know that health isn't just about healthcare itself. It's heavily influenced by socioeconomic status. And supporting clients through these other pieces of their lives can have significant impacts on their healthcare outcomes. And of course, since we're talking about food insecurity, it's really important that we reflect on our own biases and attitudes around food. As I mentioned, food is so deeply personal to all of us, and we're also swarmed with food nutrition information and decisions on a daily basis. Because of this, we really need to be sensitive to client experiences around food. Although food is a basic human right, good nutrition really is a privilege for most people. I really like this pyramid that's on the slide. It comes from Ellen Satter and is called her hierarchy of food needs, similarly structured to Maslow's hierarchy of needs. You can find it online if you wanted to learn more about it. But really, it's about acknowledging that when basic needs aren't being met, fed is best, enough food is best, whatever that might be. We can make our interactions with clients a safer space by avoiding food shaming and recognizing that there's probably a why behind food choices or meal frequency or medication compliance or appointment attendance. So I hope you got some ideas from today to take back to your own workplace and practice, and that you feel more well-versed in what exactly food insecurity is, the causes and implications, and how it's impacting clients here in the North, and how you can incorporate some of those considerations into your existing practices in your workplace. And I hope you'll be a voice on food insecurity. Maybe you'll share with one of your colleagues and they'll learn something new from you, and we'll kind of snowball. I am sharing a few resources that were either discussed through this presentation or relevant to today's presentation. All of these links should be clickable on your screen right now if you wanted to open any of them up. But as I mentioned, the webinar is being recorded right now, and I will share a PDF of the slides with everybody that is registered. So you can always reference back to this if you want.